Awesome, awesome, awesome. Thank you, Robin, for that beautiful singing music. And I just want to take this pause and take this opportunity to welcome all of you to this Women's Health Talk. What do women want to know? Um, and appreciate God for giving us this opportunity to get started and to be here. And thank you. I see the host is already here. So you ladies, I hope you are all ready for her. Um, we're gonna give it one song for Robin to bless us, and then we're gonna start with a word of prayer after that. So thank you, Robin. You can go.
All right. He loves us. Oh, how he loves us. Oh, how he loves us. Oh, how he loves. He loves us. Oh, how he loves us. And there's not a place your mercy and grace won't find me again, again and again. Lord, there's nothing greater than you, Lord. There's nothing better than you, Lord. There's nothing, nothing is better than you. Yes.
Thank you. Thank you. Praise the Lord. Beautiful. Thank you, Robin.
Eva, thank you.
Thank you. Just to introduce Robin, do you want to tell us who you are before we start with the word of prayer?
Well, my name is Robin Wakeman, and I'm one of the worship leaders at our church, and I'm also a recording artist and stuff. And so, I've enjoyed praising and worshiping. Music is who I am, and I praise the Lord for giving me the opportunity to be with you here, Eva, and to be with your charity and your fundraiser. And I, appreciate you giving me this opportunity. And
Thank you.
I had come out with an album a while back. It's called Everlasting, Everlasting. And if you want to check it out and check out my website, it's a www.rawpraise.us, not .com, .us. So just wanted to say, I want to plug that in and just say I'm just very happy to be here. And I thank you very much, Eva.
Thank you. Thank you. We enjoyed listening to you, and the singing is beautiful. We can't wait for next time. Okay, thank you. We go to another session. We're going to open this session with a word of prayer. And Dr. Mary Karogi, Mom, are you there?
Yes, I am. Let's pray. Loving Father, we thank you for giving us this opportunity this morning that we may come before your presence and learn. You are the one who have told us that knowledge is important. You've told us that in your word. And that's why we come this morning as women wanting to know so that we can be the best that you want us to be for your work that is ahead of us. We thank you and we worship you this morning. We are in your presence, oh God, and we want to learn. We want to understand so that, God, we can serve you in the best way possible. We thank you even for our host, Eva, and we thank you for these wonderful people that we have in this meeting. Thank you for the worship that you have allowed us to have this morning. I want to thank you. Our hearts are lifted to you. Our minds are focused on you, and our minds are here to learn so that we can be the best that we can. Thank you, Lord, even for them that are just about to log in. Thank you for us who are logged in. May we learn in your presence. In Jesus' name, amen.
Amen. Amen. Amen. Thank you, Mom. Appreciate you. And now, before we invite our Dr. Frost, who's been here patiently waiting for us. I'm gonna just remind everyone to stay muted. Please use the reaction part of the bottom part of your screen. Is a reaction to raise, and you can to raise your hand if you have a question, so that we are not kind of talking over one another, because this is going to be one of a kind Q&A Q&A session where we have the opportunity to ask a doctor OBGYN questions without time limit. You're not in the office where you have 10 minutes to see the doctor and you have all your questions answered. So we have more than that, and we are so graciously blessed. Thank you, ma'am, for that, Dr. Karogi, for that prayer. I can already feel the impact. So we are going to know who our doctor is for today. And Sarah, she's there ready to introduce us to Dr. Frost. Sarah, you're muted. Okay.
sorry. Give me just a moment. Can you hear me?
Yes, sure.
Okay. Thank you for joining us, Dr. Frost. Dr. Frost is an OBGYN with the Ascension St. John Hospital in Detroit, Michigan. She has been in practice for 13 years, the majority of which was spent as the owner and solo physician of her former private practice. She enjoys educating women about their health and seeing God in the lives of her patients. Additionally, she serves as the commission chair of the Women's Health Physicians and Dentists in Christ, and as an elder at the Detroit World Outreach Church. She has served abroad in missions in Jamaica, Brazil, Kenya, and Uganda. She is happily married to Darren Clark and enjoys traveling, cooking, reading, exercising, listening to music, and spending time with friends and family. So thank you for joining us.
Well, thank you all for having me. It's such a blessing and an honor to be here today. I hope that you can hear me well. If you can't, please let me know. Oh, this screen just got really large and I don't know why. So I may have to have my husband help me out with this. But anyway, what I'll do is I'll stop my video for a moment and at least you can still hear me. I am just so honored to be here today, and I want to thank Miss Eva for reaching out to me and for inviting me to come today. I'm so grateful for Grace Resource Ministries and what she and the nonprofit are doing to educate women about their health, because it's so important, and women have a lot of questions about their health. And so that's why I thought it would be best to have a Q&A type setup, because I just know when I've done this before that the women tend to have many questions, and they tend to like to interact more than they do to listen to a lecture. So I can get us started, but then after that, you know, we can just jump in with questions. And Miss Eva did, oh, my video is better now. Okay, my husband helped me. It got a little bit, it zoomed in a lot. Yeah, but it's better. So anyway, thank you. Sorry for that interruption. But there were a few topics that Miss Eva sent to me that some of you have sent in that you were interested in, one being menopause, perimenopause, and birth control. Now, if there are other topics that you want to discuss, nothing is off limits. I can't guarantee that I can answer every single question, but I do see a lot of women each day. And so I do hear a lot of the same questions and concerns. And it seems that here we may have a range of ages of women, which is great because at each stage of life, there are different concerns. So don't feel that if we're spending a lot of time on menopause that you can't ask about your cycle or about, you know, having babies or what have you. We just want to cover as much as we can and make sure that we're addressing the questions that you may have today. So that's why the topic is what women want to know, because there's so many things that women want to know and they have lots of questions about their bodies. And sometimes, you know, you all may be going through the same things, but you just don't talk about it. And so that's why I'm glad that we have the opportunity today to talk about some of these things. So please feel free and open to ask your questions. So to start, does anyone have any burning questions right now? If not, then I'll start with some of the topics that were sent in. Doesn't look like we have any questions just yet. Okay, so let's start with menopause. And I'm just going to tell you some of the things that I see women asking commonly about menopause. The first question that they ask is, how do I know that I'm in menopause? Another question is, you know, I think my hormones are off. Am I going through menopause? Or my cycle seems to be off, you know, or I'm skipping, or I'm having hot flashes. I think I might be in menopause. And so I have a very simple answer for the menopause question. And you may think that it's more difficult than what it is, but actually what we use to determine if someone is in menopause is once their period pauses. So the period has to stop for 12 months in a row in order for that to be considered menopause. And if, let's say, you've gone 8 months and then the next month the period comes, you have to start all over with your time. Now, once someone's in menopause, meaning they've had 12 months in a row, no cycle, then if you start bleeding again, we don't call that a period. We call that postmenopausal bleeding, and that needs to be addressed. And some women don't realize that, and then they end up coming in, you know, several months or several years later, and they tell me, oh yeah, I hadn't had a period for like 5 years, and then I started bleeding here and there once a month. Maybe I was spotting a little bit. And I tell them, oh, we need to look into this because there are other things that can cause this abnormal bleeding, one being a cancer of the uterus. Most of the time it's not that, but it can be. And sometimes there can be other things in the uterus like polyps. Those are like little overgrowths of tissue, or there could be fibroids, or the tissue in the lining of the uterus could just be very thin, and that's what's causing the bleeding. So please keep in mind, if you have stopped your period for 12 months in a row and now you're starting up again, don't overlook it. Don't think your body's just kicking back in. You need to see your doctor so that they can look into it further. Now, I want to give you an exception to this bleeding issue. Some people are on birth control, and if you're on birth control, and let's say you're nearing 50 years old, because the average age of menopause is 51, you may not have periods, and so we may not be able to tell when you're in menopause until you stop that birth control, and then we can see what your body is doing naturally. The other instance where it may be difficult to tell if you're menopause is if you've had your uterus removed. So we call that a hysterectomy. And so if your uterus has been removed, and even if you still have your ovaries, you're not going to have a period where you're bleeding. And so sometimes we have to use blood work to try to determine if you're in menopause, or we try to see if you're having other symptoms like hot flashes or vaginal dryness. And then we can tell that way. So does anyone have any questions about what I just explained or about menopause in general? And if you don't feel comfortable saying it out loud, you can always put it in the chat too. And then Miss Eva can help me if I can't see the questions in the chat. Okay, I'm going to keep going. And I want to tell you a little bit more about menopause while you're thinking of questions. So with menopause, things change. So remember I told you stop having your cycles for 12 months in a row. Now we're in menopause. So what happens? What are the concerns that we have? First of all, the risk of heart disease goes up significantly after a woman stops having her cycle and she's in menopause. And so it's very important that you're following up with your primary care doctor to check your cholesterol. If you smoke cigarettes, we encourage you not to, because that can increase your risk of a heart attack. And it's good to follow a healthy diet and to exercise. The other thing that we see in menopause is that you have bone loss. So within the first 5 years of you entering into menopause, your bones start to become weaker. And so it's very important that you are taking enough calcium and vitamin D. And you can get that from your food, but sometimes you just can't get quite enough from your food. So if you want to know how much do I need if I'm in menopause for my bones to try to keep them strong, you need about 2,000 international units, so that'll say IU, of vitamin D every day. And you also need 1,200 milligrams of calcium every day. But you can't just take a one tablet of 1,200 milligrams of calcium, because that it won't get absorbed in your system. So you have to divide that up. And usually we say try to get 600 milligrams twice a day. Now you have to keep in mind that you're getting some calcium from your food, which would be dairy products, or if you can't have dairy products, then it would be like almond milk or coconut milk. Those types of things have calcium. Orange juice has calcium. And then there's other foods that have vitamin D. So you want to add everything up that you're ingesting, first the food, and then you can supplement the rest to try to protect your bones. Now, remember, I mentioned exercise and how important that is. It's not only so you can have a healthy heart, but it's also so that your bones can be strong. And the types of exercises that are good for your bones are what we call weight-bearing exercises, like walking. You're using your own weight to walk, and that helps your bones to remain healthy and strong. There's a test that we do actually in menopause to check the bones, and it's called a bone mineral density test. And it will let us know if your bones are normal or if they are starting to get weak or if they are very brittle. If they're very brittle, then you're at risk for having a fracture or a break in the bone. And we look at the hip bone and the spine area. And if you have a fracture or a break of a bone in your hip or your back, that can be very detrimental to the point where you won't be able to walk and the healing time can be very long. And so that's why it's so important that we educate you about prevention, because we'd rather prevent these things than for you to have to endure these things and then we have to treat them after the fact. There are medications that we use if somebody has brittle bones that can help to strengthen the bones. But with every medication, there can be side effects. And so I'm not against medication. It's just that if we can prevent it ahead of time, maybe we could lessen the chances of you needing medication. And keep in mind, if you have a family history of brittle bones like osteoporosis, we would want to screen you a little bit early for your bone density test than usual. The usual time is age 65, but if you have risk factors, sometimes we'll do it at 50, 55. It just depends on your family history. Okay, I see some things happening in the chat. So let's see what we have here. Is it safe for perimenopausal women to use birth control for other conditions like acne? Yes, that's a very good question, because we do find that sometimes as women age, they start to get more acne. And I know you're like, wait a minute, I had this when I was younger, or maybe I didn't have it when I was younger. I know of other teenage young women that had it, and now why am I getting these bumps and things? Some women around their period will notice that they're getting acne, and that's just from the hormonal changes. And then others may have like full-blown acne that's present all the time. So yes, you can use birth control to help control that, even if you're in perimenopause, but we have to look at your risk factors to make sure it's still safe. So if you are over 35 and if you have high blood pressure, or at any age, if you have severe migraines, meaning you lose eyesight, or you have like numbness, tingling, weakness, or like facial drooping on one side with your migraines, then we don't want to use certain types of birth control. And those would be the ones that have estrogen in them. So again, if you're over 35 with high blood pressure, if you have really bad migraines, if you've ever had a blood clot in your leg or lung, you can't use those hormones, especially with estrogen. And then if you smoke cigarettes and you're over 35, we recommend that you do not use birth control with estrogen. Now, if you don't fall in those categories, in general, you should be able to use birth control with estrogen and progesterone, because the two together help with reducing that acne. And you can use that birth control up to age 51, somewhere between 51 and 55. Usually we'll stick with 51 because that is the average age of menopause. And by then, hopefully you won't be having those issues. There are other health conditions I'm sure that I haven't mentioned, like breast cancer. You can't use hormones if you've had breast cancer before. And so make sure that you talk with your physician about your specific medical conditions to make sure that it's safe for you to use the birth control. But yes, that was a great question, because some women think, oh, if I'm 45 or if I'm 49, I can't use birth control. And you can, as long as you don't have certain health risks. Okay, now there's another question. Oh, is there a possibility for women with PCOS to get pregnant? Is there a treatment for endometriosis for young women without the use of hormones? Good question. Okay, so first of all, Is there a possibility for women with PCOS to get pregnant? Absolutely. Some women, okay, so first of all, you may not all know what PCOS is. So polycystic ovarian syndrome, that's what PCOS stands for. And it is a hormonal imbalance that causes certain women not to be able to get pregnant because one of the things that happens is they're not ovulating, meaning they're not releasing an egg each month. And if you don't release the egg each month, then you can't get pregnant. But there are some women with PCOS that end up releasing an egg sometime. So they may not release it every month, but they may release one every couple of months. So there are women who have naturally gotten pregnant even though they've had PCOS. One of the things that we recommend just in general with PCOS to help with ovulation is weight loss. So some women with PCOS find that they are overweight, and we ask that you try to lose about 5% of your weight. So let's say someone weighs 200 pounds and they have PCOS. Rather than saying, okay, let's lose 50 pounds, that's too great of a goal and you may get frustrated. So let's start with 5%, and that would be 10 pounds. Let's work towards that. And sometimes just losing 5% of your weight is enough to let your body kick in to start ovulating. There's another part to PCOS that we look at, and that is insulin resistance. Insulin is used in your body to try to get your blood sugar to be controlled, to be normal. But some people with PCOS, their body's resistant to insulin, meaning their body, it produces the insulin, but the body doesn't respond to it. And it has to do with these hormonal imbalances. And when we see that with PCOS, that too can keep a woman from ovulating every month. So one thing that we will recommend, if we can prove through the blood work that someone is like pre-diabetic or leaning towards diabetes, we will put them on a medication called metformin, and that helps their body to become more sensitive to the insulin so that their blood sugar can be better controlled and to help reduce their chances of developing diabetes down the line. And also that then helps them to ovulate. So we don't recommend that a woman is placed on metformin for everybody that has PCOS, only if they have signs that they're pre-diabetic or resistant to insulin. Now, let's say that a woman either is not overweight or she's lost weight and still she's not ovulating. There are medications that we can offer to you to help you to ovulate if you choose to go in that direction. And I have had patients that have used the medication to get pregnant. And so that is an option too. Now, the other question was about endometriosis. That is such a hard and challenging condition. And I'm praying that we can find more solutions for endometriosis. So let's talk about endometriosis. A lot of women come in and they ask me, they say, do I have endometriosis? First of all, let's define what endometriosis is. Endometriosis is where the lining of the uterus, those glands where we bleed from every month, like from the womb where a baby sits, that same tissue is found in other parts of the body, such as on your ovaries, it could be on the bowel, it could be on the bladder. I have one patient where it impacts her lungs. It traveled all the way up there to her lungs, and she sometimes has breathing difficulty with her period. Because what happens is, as you cycle every month and you have a period and your uterus starts to bleed normally, the tissue that's outside the uterus, that's in other parts of the body, it also is cycling. So women may experience pain when they're having a bowel movement, pain when they're passing gas around their period, pain with urination, painful intercourse. Sometimes they have pain outside their period, and they tell me their periods are just excruciatingly painful. Sometimes they have nausea and vomiting with it. So endometriosis can have varying effects, meaning that some women can have a lot of that tissue all throughout their body and they barely have any symptoms. And then somebody else could have just a little dot of tissue near their ovary, and then they're just doubled over in pain with their period. Endometriosis can also cause certain cysts on the ovaries that we call chocolate cysts. And those can sometimes cause pain, and in some women they don't. So that's basically a little synopsis or summary of endometriosis. It's a very, very big topic, so there's a lot that can be said about it. But in terms of this question about whether we can use other treatments besides hormones for endometriosis, truthfully, I have not seen a lot of therapeutic, like helpful things for endometriosis outside of the hormones, although I personally have been looking into essential oils and things to try to see if there's other ways that we can manage it. I haven't had a patient try the oils, but that is something, you know, an alternative way to go. If you didn't want to use the hormones, you could look into certain type of essential oils that can be applied to your abdomen to help with the pain. That doesn't get down to the nitty gritty of it to try to treat it, but it does help. It can help with the symptoms. There are some women that in general, when they have painful periods, they go for acupuncture. Acupuncture has been shown to be helpful for painful periods alone. It may not be as effective in women with endometriosis. It just depends because everybody is different. We do sometimes send women for pelvic floor physical therapy if they find that their muscles are really tight, because when they're in pain, they're contracting everything, kind of like when you have a painful neck area and shoulder area because everything's so tense. Well, down in the pelvic area where women are having pain every month, they end up tensing up down there. So then in addition to the endometriosis, they're having pelvic pain. So sometimes to alleviate that, we send women to see a physical therapist that can help them with relaxing those muscles down below. Now, I have had some other patients tell me that if they follow a really clean diet, eating very well and exercising regularly, that has helped them with their endometriosis pain. Because some of those people, they can't tolerate the medications that we offer. So those are some things that you can try to do. And for some women that works well. And then for others, they end up needing more. But I wish we did have more to offer on the alternative side for endometriosis, and maybe we will down the line. The other thing that I'm thinking of that we use just in general for pain with periods, which could be related to endometriosis, is something called a TENS unit. That's TENS, TENS. And it's basically a device that gives you electrical nerve stimulation. And you can buy these. You can look on YouTube and see of the types that are out there. One of them is called Ovira, Ovira. And you can attach the device to your lower abdomen, and it'll give you a little electrical nerve stimulation that can help you with pain. So those are some things that you can try for endometriosis. And some people try stretching, relaxation techniques, just trying to avoid sugars and things that can be inflammatory. But it really, really depends on your own body because everybody responds differently. So thank you for asking that question. Okay, I've heard the word endometriosis, but I don't know much about it. What is endometriosis? So did I answer that question about what endometriosis is, or do you have more questions about it?
You answered it. Thank you.
Oh, you're welcome. Okay. Okay, we're moving on to breast pain. So I have been having breast pain for 2 years now, was on Indeed for 2 years, thought it was causing pain and got removed, but 1 month later, still having pain, no mass or bumps, pallets. I'm 35 years old and doctor says I can't have a mammogram at this age, was on IUD. Okay, and so this Indeed, what was the Indeed, if you could clarify that? And while I'm waiting for that clarification, I can tell you, unless you're going to talk, I don't want to talk over you. You can either type it in or you can speak to me. Let me see. Okay, so while I'm waiting to hear about the Indeed, Oh, intrauterine device, the IUD, that's what that was. Okay, I've got you, I got you. And was that a hormonal IUD or was it the non-hormonal IUD? Because there's different types. The one with progesterone or the copper IUD, if you remember. Hormonal, okay, okay. So breast pain is something that is common that we hear about. If it's involving both breasts, then we feel that it could be something hormonal and less pathologic, meaning if it was one breast that's painful, we like to look and make sure that there's nothing else going on with that one breast. If it's both breasts and we think, oh, you know, it may be similar to what a woman feels when she is going to be starting her period or after she's ovulated, she gets this breast tenderness. And so I'll address both of them. So if we have a woman that comes in and she is having breast pain, just one breast, a lot of times we like to ask, okay, is it occurring all through the month? Is it happening just around your period? How long has it been happening? And like Anne had mentioned, we like to know, are there any masses or bumps there? Are there any skin changes? Because if you see skin changes, like if your breast skin starts to look like an orange peel, not the color, but the consistency, that lumpy, bumpy, firm skin change, we get concerned about that. We also ask about any nipple discharge. Is there discharge coming out? Is it clear? Is it white? What have you? Is it red like blood? And so, and then we like to know, are you feeling anything under your armpit? We call that the axilla. So there's several questions that we're asking to try to figure out what may be the cause of this breast pain. And so usually what we'll do is have you come in for an exam and we will see, when we are examining you, is the breast tender? Sometimes it is, sometimes it's not. And then we try to locate where that tenderness is. Is it involving the entire breast or is it just involving one part? So usually when we examine the breast, we look at it like a clock. So if you look at the breast, if I'm looking right at the patient and looking at one of the breasts, 12 o'clock is up top, then there's 3 o'clock, 6 o'clock, and 9 o'clock. And that's how we document where the woman may be having trouble. And that's very important because if we order a test like an ultrasound, then we can say, oh yes, her pain is at 3 o'clock on this side, on the left breast, and that is also where I feel a lump. Or no, I don't feel a lump, but she's tender in that area. So from there, we would move on whether we felt a lump or not. Usually we'll order an ultrasound of that breast to try to see, are there cysts there? Is there just dense tissue? So dense tissue is compact tissue, meaning if you all know what tofu looks like, or something else that kind of like butter, you know, something really, really tight and packed, that's what dense tissue is. And a lot of young women have dense tissue. And so you may check your breast and you may feel, oh, this doesn't feel like a lump or bump, but it just feels a little firm right there. And it may feel a little tender. And around your cycle, you may notice that. That's what we call dense tissue. So that's what we're looking for on the ultrasound. And dense tissue can be a cause of breast pain. Okay. Now, so for Anne, if the doctor says you're too young to get a mammogram, which we have gotten mammograms in someone who's 35, but the issue with you is you may have dense tissue because you're young, and so the mammogram may not pick up as much. Maybe what you could consider is a breast ultrasound. The ultrasound can look for other things that the mammogram doesn't, and it can still detect dense tissue. So you may want to consider that. Now, let's say you're having breast pain from both breasts. Okay, so we go through the same process of asking all the questions, doing the exam. But again, then I'm thinking, okay, maybe this is more hormonal. Maybe it's happening around the cycle. We start asking questions also about your diet. Are you eating or drinking things with caffeine? So that's coffee, tea, even chocolate. Chocolate has caffeine, and don't forget about pop or soda. I'm in Michigan. I think some of you are out of state, so you may say it differently, but pop or soda has caffeine, and that can also contribute to your breast pain. So we start by saying, cut those things out. And usually I get a frown face for those that love their pop or their their coffee and they're like, oh no. And then I say, well, you want the breast pain or you want to cut out the pop and the coffee? And so usually they'll say, okay, I'll try it. The other thing I talk to them about is the actual bra that they're wearing, because, you know, ladies, we can't wear these bras forever. I know they're expensive and we may not want to buy anymore, but they do wear out. So I encourage women to get properly fitted for a bra, because oftentimes we don't even know how to wear the bra. I mean, who teaches you really how to wear the bra? We just kind of get it and we put it on and we're like, okay, I think that's right. But I learned even in the last few years that I was doing something wrong. You know how when you have your bra, and usually I'll try to tighten it to the tightest one. And that's not what you're supposed to do. When you first buy a bra, you put it on the loosest one, and then over time the bra is going to loosen up because it's going to become more elastic, and then you're going to keep tightening it and then tighten it more. So even something just as simple as that, I didn't even know myself in the last few years, because it's just something that women don't talk about. We just kind of try to figure it out ourselves. But having the appropriate fitting bra is very important. So if you've never been fitted for a bra, I encourage you to go to a department store or a bra store and let them fit you, especially if your weight has changed. Over time, our bodies change. You may not be able to wear that same bra you had 15 years ago, which we probably shouldn't keep that one that long anyway. But if you're wearing a bra that doesn't fit you well, you may have breast pain, especially if you have large breasts and they're hanging down and you don't have good support. That can cause back pain and breast pain. Okay, so what are some other things that we do regarding breast pain besides cutting out the caffeine and working on a properly fitted bra? Some other things that we can try, there's something called evening primrose oil that you can try. And then there's also black seed oil that you can take that can be helpful for breast pain. Usually we don't prescribe medications for it, but you can try those supplements and that can be helpful. Another thing that I heard of recently that sounds interesting to me that I think is worth trying, there is an essential oil called frankincense. And I have heard that applying frankincense to the breast can be helpful, especially for women that have fibrocystic breasts. So remember, I talked about dense breasts. If you have that tofu, something that's real compact, and you have bits of that in your breast, that can cause pain. And we call that fibrocystic breast because it's a mixture of that dense tissue and little cysts. Okay, and so you can change your diet, but you can also apply frankincense, and you may find that that is helpful for your breast pain. So I would say for Anne again, and anyone else that may be having some breast pain, and if you haven't had any imaging of the breast, no pictures of the breast, and if the doctor doesn't feel comfortable with the mammogram because of your age, I would say the next step definitely would be getting the ultrasound to see what's there, if there is anything there. And if there's nothing there, then you may want to try some of these other tips to see if that can help reduce your pain. Okay. How do you find out the best birth control to use when you are still getting babies? So I might need a little bit more clarification on that. What do you mean by when you are still getting babies? Does that mean you're getting pregnant when you're on birth control?
I think she meant those during the years when in the birth. I mean, during those years of birth, when women are giving birth. I mean, like 20s, 30s, 40s.
That time. So when they're still in their reproductive years,
Yes.
what birth control is good? And do you think maybe she was concerned about the birth control affecting their ability to have babies down the line? Possibly.
She probably talking about different.
Or even affecting your health, because some of them do affect your health.
Okay, so now it's hard to say the best, because when we are prescribing birth control, we have to individualize it to the patient because every patient is different. So what's best for one person is not going to be best for another person based on their needs, based on their financial situation, based on their medical conditions, based on their age or their body type. So there's so many things, but I can review some of the pros and cons of the birth control that we have. But then what we do is we have to individualize it for each person and then also discuss what are their wishes. Because some people tell me, you know what, I'm not going to keep up with those pills. I'm going to forget, and then others say, I don't want anything put in my body. I don't feel comfortable with that. Others say, no, I want this thing in me because I want to make sure I'm not going to get pregnant and it's going to last me a while. I don't even want to think about it. So there's a lot of variables. But let's start with the hormonal options, and I can tell you about the non-hormonal options. And then there's also natural family planning. Excuse me. So for hormones, usually what we talk about is we go from hormones that are used daily to hormones that are used yearly or every couple of years. So there's birth control pills. There's two different types of birth control pills. There's many types of pills, but in terms of the class of birth control, there's what we call combined oral contraceptives, meaning they're pills that have both estrogen and progesterone in them. And then there's ones that just have the progesterone only. Some people will use the progesterone only pill if they're breastfeeding because they don't want the birth control to impact their breast milk. Usually, if you're 6 weeks postpartum, meaning it's 6 weeks since you've had a baby or longer, most of the time, if your breast milk is coming in well, you can use any of the birth control based on your health history. But if you want to be extra safe and extra careful in terms of watching your breast milk production, then sometimes we'll offer the progesterone only options. And one of those is a progesterone only pill. That one you have to take the same time every day. If you miss it by 3 hours or more, you can get pregnant. So you have to be very diligent with that one. And all the pills in the pack are active. So there's no pills in the pack that are sugar pills, that are placebo pills. Every single pill in that pack has hormone. So what happens is sometimes you don't have a period, or sometimes you can get irregular bleeding that as a side effect. The other birth control, which we kind of say regular birth control because it has the estrogen and progesterone in there. That one is the one, again, that can help with acne. The progesterone only pill may not help with acne. A lot of young people come in, they may be going to college, they may have problems with their period, or they may be concerned that they're going to, get into a relationship and they don't want to get pregnant. And so then they end up a lot of times choosing the pill because they're not ready themselves to start something else that's more long-term. And so we do find a lot of young people using the pills. Some of the benefits of the birth control pills can be reducing your risk of ovarian cancer because you're not ovulating, helping with acne, reducing the risk of uterine cancer because it keeps the lining of the uterus thin. Sometimes it will lighten the period. Sometimes the period stops. Now, some people get concerned about that. It's not that it's holding anything back or that you're collecting blood that needs to come out. It's just that the lining of the uterus is thin and there's nothing that needs to come out. And that's why sometimes women don't have a period when they're on certain types of birth control. The risk with birth control that has estrogen in it, you can have a risk of blood clots in the leg or lung. So that's why I always ask before giving it to anyone, do you have a family history of blood clots in the legs or lung? Because there are some conditions that run in families, and there's a genetic cause that can cause you to be at risk for blood clots. And in those situations, we will test the patients to see if they have that blood clotting disorder, if they have that family history, because if they do, they shouldn't be on birth control that has estrogen because they could get a blood clot. And blood clots, if it gets to your lung, it can be deadly, meaning you can die. Now, the risk of blood clots with birth control is lower than your risk of a blood clot just being pregnant. So when you're pregnant, you're at risk for blood clots, and especially in the postpartum period, just by being pregnant. And so the risk of the blood clot is lower by taking birth control than by being pregnant. And so we try to put that in perspective for people when they're trying to make the decision about whether they should use hormonal birth control or not. So those are pills, something that you take every day. Other side effects, some people get migraines, headaches, some people get nausea, some people have mood changes. So I ask them, do you have depression? Do you have anxiety? How bad is it? Are you on medication? Do you see a psychiatrist? Have you tried to commit suicide? You know, all of those things are important to ask before you start, because if their mood changes are significant, I may not even start them on it. And I want them to see their counselor or psychiatrist and make sure that their mood is stable. And we work together to find something that's going to work well for them. But if you do have depression or anxiety, it doesn't mean you can't be on these. We just have to be careful because sometimes we see mood changes. Okay, then there's the patch. The patch is something that you use once a week and you put it in different parts of the body. So once a week for 3 weeks, you wear this patch. You change it every week. Then the 4th week, you take the patch off and you leave it off. And that's the time to have the period. So for people that say, hey, you know what? I'm not good with taking something every day. I'd rather have this patch. I can do better with something once a week. Now, one thing we were careful with the patch is that some evidence came out several years ago that women that use the patch are exposed to a slightly higher dose of estrogen overall than the women that use just the birth control pills that have estrogen and progesterone. And so the question is, since you're being exposed to a slightly higher dose of estrogen overall, does that increase your risk of a blood clot or not? And theoretically, it could be. You know, it's not proven, but, you know, we have to counsel people about that. And so if they have other risk factors for blood clots, then we may say, maybe you don't want to use the patch. So we use the patch, but we use it with caution. Then there's the ring. The ring has both estrogen and progesterone. Sometimes I'll use this in somebody if they tell me they have nausea. It doesn't mean they won't have nausea with this, but some people, they just have nausea and vomiting with the pills. So sometimes we'll try the vaginal route to see, well, maybe you won't have the nausea and vomiting with this form. Also, this one you use once a month. So the patient puts it in the vagina themselves. It doesn't get lost. So people say, what if I push it up too far? Or do I have to put it, do I have to get it around the cervix? How do I know it's in the right spot? So basically, you just have to get it in and get it right behind your pubic bone, which you can feel when you put your finger down there. And it lasts for a whole month. So 3 weeks, you leave it in. Then that last week, you take it out. And then for a week, and then you start all over again. So that's good for people that they don't want to take something every day. They don't want to take something weekly. And they don't mind putting the ring down there. Now, I get a lot of people that say, you know what, I don't want to put that down there. You can still have intercourse with the ring. And if the ring comes out, it can stay out of your body for 3 hours and still be effective for birth control. You don't have to take it out every day and clean it and do all of that. But if it does come out for some reason, then you can rinse it off and put it back in. And the ring, the patch, and the pills have the same risk factors because they're all birth control that has estrogen and progesterone. Then there's the shot, the Depo-Provera shot. It's progesterone only. It's something that a lot of people were taking years ago. We have other options now, so we don't use this one as much. But this type of birth control is an injection that you get in the doctor's office every 3 months. So some people like that because then they're not taking it as often. But there are several side effects with this medication. We see weight gain, significant weight gain. I think it makes people hungry. And so I've seen people gain like 40 pounds on the medication. And there's been hair loss, headaches. It can stop the period for people that want their period to stop. And the other thing is there can be irregular bleeding. With any of the birth control, there can be irregular bleeding, but we can see it sometimes more with the shot. And the other concern I have with the shot is if you don't like it, it doesn't just get out of your system quickly. You can see some of the effects of the shot for up to a year after it's been put in your body. So let's say you're planning to get pregnant in a few months or in a year. I don't suggest the shot because I don't know when it's going to clear from your body and when your body will start ovulating again. So it's better for a long-term option. But here's the other thing in terms of long-term, we have found now that if you're using it for 2 years or longer, that it can cause bone loss. So remember, I talked to you earlier about menopause and how when you're in menopause, within the first couple of years, you can have bone loss. And sorry, my screen had just changed. Here we are. And so we're finding that when women use the Depo-Provera shot for longer than 2 years, that they're having problems with their bones. And so I try to encourage the young people not to get that, because they need something. If they're going to use something, they need something reliable and effective that's not going to impact their bones long term. However, if that's the only option and they really don't want to get pregnant, then we use it. And we just tell them to make sure they're taking calcium and vitamin D to protect their bones. The next one is an implant that can be placed in the arm. We place it in the arm in the office, and it lasts for 3 years. It can last longer than that, but the manufacturer says 3 years. And so that one is progesterone only. We don't see as many changes with the weight as we do with the shot, the progesterone only shot I just told you about. Oh, my camera's changing again. Can you fix the camera, honey? And so the implant, like I said, it lasts 3 years. I've seen that sometimes people have problems with their with anxiety. Not always, but some people have told me that the anxiety is worse. And then the other thing that we see is irregular bleeding and spotting for, that can last for the whole 3 years. And so that can be problematic. And so I find that sometimes people want me to take that one out because they just don't like the spotting. Some women, they don't have a period anymore, and so then they don't mind. And the last one is the IUDs. And so Anne had mentioned the IUD. There's different types of IUDs. And so there's the progesterone only IUD, and then there is the copper IUD. The copper IUD lasts 10 years, and that one, it can make your period a little heavier and a little more painful. So in women that already have painful periods, I tell them not to get that one, because they won't be happy with it. Now the progesterone, the progesterone only IUDs, there's 3. And so the most common one is the Mirena IUD. And that one lasts about 5 years. It can last longer. And then the other one is Kylena. It's a smaller IUD. It lasts 5 years. It doesn't have the same impact on the period as the Mirena IUD. The Mirena IUD is FDA approved for use in women that have heavy menstrual bleeding. We use it in that may have bleeding from fibroids or this other, heavy bleeding, and they also need birth control, and they don't want surgery. It's convenient because it lasts several years. The Kylena will last 5 years. Sometimes we give that to college-age women. Okay, I don't really take the chance of any or other side effects, but I want something that's last, about 5 years. So then that one. And then there's the Skyla last 3 years, and I don't use that because people with that, and nobody is spotting. I'm gonna double check this here. Okay, we're back in motion. So as you can see, there's so many types of birth control, and I do have just a few more to tell you. The non-hormonal ones, in addition to the Paragard IUD, the copper IUD, would be some people use condoms. Some people have sensitivity to condoms, and so can use the latex-free condom if need be. Some people use more of like the animal type skin condom, but that one doesn't protect you against sexually transmitted infections. So you have to be careful with that if that is a concern of yours. And then some people will just use a family plan where they use their period tracker and they can tell where they're ovulating every month, and they try not to have intercourse around that time for about a week before and a few days after ovulation. Or they'll use some type of barrier protection like around the time of ovulation. The last 2 are, you can have, some people permanent sterilization, meaning they don't want to have any children, and so they talk about getting their tubes, or they have their sponsor partner have a vasectomy. And that's permanent. So there's no, I mean, you can hear reversals and things, but we usually say, don't plan on reversing it. If you're planning to get this, plan on it permanent, because the having a pregnancy. Lastly, there's a new vaginal gel that is out for birth control. It's not hormonal. What it does is it helps to keep the pH of the vagina low so that can't really to reach the egg. So it's not a spermicide because spermicides can have a lot of side effects, and the spermicide is not as effective as this new gel. But that is called Phexi with a Phexxi, if you want to look into that one. I haven't had many people try that one, but you're supposed to insert it into the vagina within an hour of intercourse, and then you have to repeat it with each active intercourse. So as you can see, there's a lot of birth control options. And so it's hard to say which one is best because it's going to depend on what the patient's needs are, what their medical conditions are. And so we try to determine ourselves, the patient and I, what's going to be best for them based on their entire clinical picture, if that makes sense. But any of them can be used if you're in that reproductive time. Even IUDs can be used if you want to have babies in the future. We don't tell people who have never had a baby that they can't have an IUD because it hasn't been shown to affect their ability to have babies down the line. The only one I caution you with is the shot. If you're trying to have a baby, within a year or two, it may delay it because I don't know when you're going to ovulate again, and it can take time. Okay. Oh, yes. I knew this one was going to come up about BV. What would you advise women with chronic BV? What therapies are there for women who have had mastectomy and hysterectomy, alleviate menopausal symptoms like vaginal dryness and hot flashes? So with the BV, that is bacterial vaginosis, is a very, very, very common condition that we deal with women, even more so than yeast. It is not sexually transmitted, but we can see it more in women who are sexually active. What happens is bacterial vaginosis is a mixture of vaginal bacteria. We call it the bad bacteria because the vagina has its own little environment down there. There's good bacteria and there's bad bacteria. And the good bacteria make something to keep the pH low in the vagina, to keep the bad bacteria in check, to keep them from overgrowing. But sometimes you can have imbalances where the bad bacteria start to outgrow the good bacteria. And in those instances, that's where we see this bacterial vaginosis. And sometimes we see this in women that are sexually active because the male's semen is more basic, it's more alkaline. So it brings the pH of the vagina up, which is a better environment for that bad bacteria to grow in. And so that is why women start to have issues. I'm not blaming it on the men. It's just an imbalance that can happen. There's other things that can cause these imbalances. Sometimes we ask you to change your soap. So some people are using soaps like Dial and Caress and Tone and all these other kind of, so Irish Springs and all of that. And I'm not going to say they definitely cause bacterial vaginosis, but we can see with certain soaps that there are changes possibly in your pH. And so usually I'll recommend that you use an oatmeal bar soap, something really plain. You can use Yardley oatmeal and almond soap if you have that in your area, or if you go to your local health food store, and if you can get like a natural soap. It doesn't have to be antibacterial. Get something like oatmeal, and the fewer ingredients on the back of the soap would be best. And so I'm mentioning a soap bar. I'm not talking about body wash. So you should get rid of all that body wash, because some people say, oh, well, it's unscented, it's natural, it's this, it's that, but they've put things in it to liquefy it. And so sometimes that can impact your pH. So try to use a bar soap. The other advice that I give is to use a vaginal probiotic. So the probiotic gives you more of that good bacteria. Remember, we want to combat that bad bacteria with good bacteria so that your pH can be low. And so I like the Garden of Life vaginal probiotic, which you can get online from Amazon, or if you don't shop there, you can go to your local health food store. And if they don't have that brand, you can get any brand of vaginal probiotic. You take it by mouth, even though it's for the vagina, and you're looking to see that it has a lot of lactobacillus in it. All different types of billions of lactobacillus, because that is what you need. That's that good bacteria that you were born with to clean the vagina and keep the pH low. And that's the other thing I want to mention. We don't recommend that you douche. Some people, they want to clean out the vagina. God built us and created us with a self-cleaning vagina, and that's with the good bacteria that we have. And so if your bacterial balance is off, then we need to restore it with the vaginal probiotic rather than trying to douche. Because when you douche, you're rinsing out the good and the bad bacteria, and it's not helping. All right, the other thing that we do, sometimes we use certain antibiotics. Now, some of you who may have had chronic bacterial vaginosis may have been given these antibiotics like metronidazole, or we call that Flagyl, or clindamycin, or a cream that can be used. And sometimes the bacteria can keep coming back though. And so women get frustrated with that. And because the bacteria can form a film over itself to make it more difficult to get rid of it. It's kind of smart. So sometimes we have to give women the antibiotic for a longer time. So we'll give them something called suppression therapy, where they're taking the antibiotic for a week, and then they may use it once or twice a week for up to 6 months. The other thing that we use sometimes is called boric acid. Yeah, and some people are like, ooh, boric acid, I don't know about that. I can tell you, don't ever take boric acid by mouth because it can kill you. So don't do that. And don't have it around children where they can put it in their mouths. But every once in a while, sometimes you can use boric acid vaginally, and that can help with the bacterial vaginosis. But we try to prevent it by changing the soap and sticking with that soap, using your vaginal probiotic, and then just kind of attacking it when it shows up. And then sometimes we just have to hit it hard with those antibiotics. So yeah, BV can be a challenging one. It can be very frustrating, but once you find a regimen that works for you, I find that women tend to do well in the long run. For women who have had a mastectomy, so they've had breast cancer, they had a hysterectomy, and they want treatment of their menopausal symptoms like vaginal dryness and hot flashes. So the reason Ms. Rose has brought this up is because not only has the person had their uterus removed, but if they had a mastectomy, that means they had breast cancer, which means there's certain hormones and things we just can't use. So in women that have hot flashes, sometimes we will use hormonal replacement therapy to help them with their symptoms. But if you've had breast cancer before, we can't use those. And so, yes, sometimes it can be challenging for women who've had breast cancer to alleviate some of these symptoms, but there's hope. So for the vaginal dryness, there are vaginal lubricants that you can use that are over the counter. There is one called Replens, that's R-E-P-L-E-N-S, Replens. And there's several others too that you can look into to see if you would like those, but you can use them 3 times a week. There's also, now during intercourse, you don't use those during intercourse. That's just for maintenance. For intercourse, if you're experiencing vaginal dryness, you can use coconut oil, just your regular old coconut oil from that you cook with, or you can use products like Astroglide or Uberlube, or sometimes people use KY jelly. There's also for hot flashes, we usually try not to have, we don't want you to use any products that have hormones, but there is a non-hormonal product by the company Bonafide, B-O-N-E-F as in Frank, I-D-E. That company has like a range, about 4 or 5 different products that they offer to women that you can buy directly from them. They're non-hormonal, and one of them is for hot flashes, which I feel would be safe to use if you've had breast cancer before. Other things are, some people just need to, if you drink alcohol, we tell you to reduce that or cut it out because that can cause you to have more hot flashes. Watch how much sugar you have in your diet and carbohydrates. Eat more vegetables. instead of the sugary stuff, and exercise. And sometimes that can help with the hot flashes too. And wear little clothing at night and keep the room cool if possible to help with those hot flashes. All right, what sort of guidelines would you recommend women to take when it comes to their safety from cervical cancer and breast cancer? How often should you get screened? And are there any lifestyle changes that can help prevent these diseases? So let's start with cervical cancer. Cervical cancer we know now, is related to the HPV virus. The HPV is a virus that's sexually transmitted, and most people, once they become sexually active, have been exposed to it. We do check for HPV when women come in for their routine annual exams. Once they're 30 years old and older, we check for that routinely. Under 30, we have a different kind of process, and it's not checked routinely because it's very common to find HPV in young people, and we want to give your body time to clear it out before we start checking for it. So we use different criteria in younger people in terms of when to check the HPV. And there's no medication for it. So that's another reason we don't just routinely check for it, because we can't give you anything for it. We have to rely on your immune system to clear it out. But in terms of reducing risk, reducing the number of sexual partners you have in your lifetime can reduce your exposure to HPV, since it is sexually transmitted. Using condoms can be helpful. It's not 100% because viruses can get through. Certain viruses can get through condoms, but that can be helpful. Coming for your routine annual visits are very helpful, because the HPV virus can cause abnormal cells. So well before it becomes a cancer, we can see abnormal cells of the cervix. And that's when we start doing further testing and further procedures to see how bad the cell changes are. So just because someone has a diagnosis of HPV, it doesn't automatically mean they have cancer, or that they're automatically going to get cancer, because a lot of people get scared about that. And I try to alleviate their fears and say, no, this is very common. We just need to follow the procedures and follow you and make sure that, the cells of the cervix don't become too abnormal. But if they become too abnormal, then we offer you treatment well before it becomes a cancer. So the most important thing that you can do is to come for your annual visits so that we can screen you for the cervical cancer, and that way we can intervene well before it becomes a cancer. Because most of the women that end up having cervical cancer are the ones who haven't been seen in 10, 15 years, and by then, whatever abnormal cells were there have progressed to a cancer. So cervical cancer can be prevented. You may have heard of the HPV vaccine that is available, that is offered to women between the ages of 9 and it was 26, and it's offered to men too, but FDA has approved it up to age 45 these days. And so that is another measure that we use as well. How often should you get screened? Well, for cervical cancer, we usually start that screening. That's with the Pap test. And that is at age 21. And usually if you're not sexually active, if you've never been sexually active, sometimes I give you a little break because the exam can be challenging, to put the speculum into the vagina. I don't want to force that if the patient isn't ready to have that type of exam. So we talk about it. But in general, the guidelines state we should start at age 21. And then after that, the guidelines state that we should screen you every 5 years. I usually do it every 3 years because I just feel more comfortable with that. But just because we say 3 or 5 years for screening, that doesn't mean you wait 3 to 5 years to come and see us. You need to come in every year because there's things we need to talk about besides just cervical cancer screening. We have to talk about your birth control or your periods or your family history of certain cancers that we need to look into, and doing your breast exam. So I try to educate the women that they need to come in every year, even if I don't have to take a Pap test every year. But I still look at the cervix, and I'm still examining the cervix and the uterus and the ovaries and the breast every year, even if I don't have to take a sample for the Pap test, which is the screening for cervical cancer. And it's very important for you to know what the doctor is doing. So don't be afraid to ask questions, because sometimes I'll ask a woman, when's the last time you had a pap test? And they said, oh, it was in the ER. And I said, nope, you didn't have a pap test in the ER. They don't do screening tests in the ER like that. They're not going to do a pap test, a screening for cervical cancer. What they did was they put the speculum in, and they're probably checking for discharge or screening you for sexually transmitted infections. So it's important to ask the doctor, hey, what are you testing me for today? Are we doing the pap test? You know, are we doing screening for sexually transmitted infections, so that you can be aware of what has been done? But just because a speculum has gone into the vagina, and just because some swabs have been taken, it doesn't mean that that was a pap test. So that's something I always like to clarify, because there's a lot of confusion with that. Now, regarding breast cancer, we are seeing younger women with breast cancer these days. And for me personally, this is my personal opinion, I think there's a lot of environmental things going on that may be contributing to that, regarding with our food and things in the environment, and even our weight changes through the years. So I think that some of these things are playing a role, some of our vitamin deficiencies. And then there's family history that plays a role. The type of breast cancer that runs in families isn't the most common breast cancer, though. Most of them are sporadic, meaning that they just show up. But we do screen women for a family history of breast cancer, because if we find that there's a lot of people in the family, including men, because men can get breast cancer. So if there's a strong family history of breast cancer, then we start screening you sooner for your breast cancer risk. And sometimes we'll send you to see a genetic counselor so that they can calculate your risk. And we offer more tests at an earlier age if we find that you're at high risk. But in general, what we do, if you don't have those risk factors, is to start mammograms at age 40. And we do them every year, because some patients say, oh, I got to get another one. And I'm like, yes, every year at age 40. Because do you know, I have had some patients who had a mammogram like 6 months prior, and then at that 6-month mark, they have cancer. And so it's so important for early detection that you get your mammogram every single year. And some people say, oh, but it's gonna hurt. I mean, I've had them, they don't hurt me, but everybody's different. But I'd say, well, would you rather have a little bit of pain for the test, or so we can know about breast cancer sooner, so we can intervene sooner? Or would you want to wait and potentially a breast cancer shows up and then it's too late? Now the breast cancer is all over your body. And I've had patients like that where they've had issues and then they come in years later with an advanced stage breast cancer, and now it's just palliative therapy. Palliative means we're just giving you medicine to help you, but the cancer is going to take its toll unless there's a miracle. But we much rather intervene when it's early, when there's just a little spot of cancer, because then there's a lot more that can be done and your recurrence risk is low, the chance of you getting cancer again. So prevention is so, so, so important. Please get screened. And there are, if you don't have insurance, there are programs available based on your finances, especially for women 40 and over, that can qualify to get coverage for their breast cancer screen and their cervical cancer screen. One of the programs is called the BCCCP program. I know we have it in our area in Michigan, and I think that it's all over the country. So you can check it out and see, but there may be similar programs in your area. And there's other low-cost health care facilities that will be willing to see you and help you too. So just please don't overlook getting the mammogram every single year. The other thing is to be aware of your breast. We call it breast awareness. We used to say check your breast every month, clinical breast or self-breast exam every month. But now they've changed it to be aware of the breast. So if something's changed, if the skin looks different, if you're noticing lumps and bumps and there's discharge coming from the nipple, then you want to get in as soon as possible so we can check it out. And then we can offer that mammogram or that ultrasound to look further. So those are some of the things that we do. Lifestyle changes to prevent the disease. For breast cancer, definitely having a healthy weight, exercise. Vitamin D plays a role, they believe. So vitamin D is good for your immune system, for your bones, for your energy level, and they also think it's helpful for the breast. And again, you may try frankincense. I can't say it's been proven to prevent breast cancer, but it may help you with some of those other breast issues like fibrocystic breasts. And And then Anne was mentioning about the breast. I know somebody who had a negative mammogram, then a few months later had a state. Yes. What is your, so she said later had a stage 4 breast cancer. What is your stand on clinical breast exam versus monthly self breast exam? Well, like I was just saying, the recommendation right now is, well, okay, clinical breast exam means in the office. And monthly self breast exam is something that the patient does themselves. So, so there is a difference. The clinical breast exam is done by a physician. And so we usually do that once a year. I'll usually start at age 19 and then continue on. Unless the patient, if she's younger than 19 and has a breast complaint, then I will do that. So you should be doing both. You should be getting the clinical breast exam, and then you can do the breast exam monthly. It's not a requirement. They haven't proven that affects the breast cancer detection rate, but being aware of the breast, being aware of any changes of the breast is very important. And if for you, if doing it monthly works, do it. You don't have to stop. But for others, they may not remember to do it monthly, but they need to be aware of any changes. And the best time to check the breast is before the period, not just before the period, but I would say after the period, once everything has settled and you're starting all over with the cycle, that's when you want to check the breast. Because just before you have your period, which is right after you ovulate, the breasts may get larger, they're tender, you're gonna feel more lumps and bumps and all that. So don't check it then. Once your period has ended, the bleeding has stopped, the bloating has stopped, everything is back to normal, then you can check it. That's the best time, because that'll give you the most accurate information about what's happening with your breasts right then and there. Is there a remedy for decreased sexual libido in postmenopausal women? What about loss of breast mass and facial hair? Yes, that's a hard one too. This decrease, the sex drive in women, postmenopausal women, can be challenging. That there is that product, so that company I was telling you about earlier, Bonafide, Bonefide, they have a product that they use for women that have issues with libido. I can't say that it's gonna work, 100%. Truthfully, in women, the medications that I've seen that they've offered, who wants to use them? Because one of the side effects can be hot flashes. So you improve your sex drive maybe, but then there's hot flashes. So I don't think there's a lot of great medicines out right now. Not that I would look into. I'm not in menopause yet, but I just haven't seen a lot that I like to offer to patients that are helpful. Sometimes we try to address the issue of vaginal dryness, because sometimes that affects a woman's desire to have sex, because she thinks it's going to hurt. So if we can work on the vaginal dryness, then that helps. Sometimes we say make sure you're having intercourse frequently, enough, because if you don't have intercourse, then it gets more dry and more tight, and if you're not using it, you kind of lose it. But then it's a cycle, because then you don't always want to have intercourse because it may be painful. So it can be challenging. But sometimes we'll use vaginal estrogen to also help to reestablish the normal vaginal anatomy and the normal discharge, and that can be helpful. Vaginal estrogen, we try not to use it for women who have had breast cancer, but there are some oncologists with certain types of breast cancers that are letting us use it, but that's very, very specialized. But in general, if you don't have breast cancer, sometimes we use vaginal estrogen in addition to the lubricants, and that can be helpful just for helping with the vaginal anatomy to make it less painful, less dry. And it doesn't increase your risk of cancer because it's such a low dose that women can continue it for the rest of their lives without being concerned about cancer of the uterus, if you have a uterus. But again, with breast cancer, we try to avoid it. Loss of breast mass. Oh yeah. So there's nothing really out there that can help you get the breast back once you get older, and you start to lose that muscle mass underneath, and then it's more fatty and they sag some. So there's not a lot to do for that. That's just a normal aging process, unless you had cosmetic surgery, to lift them up again and plump them up. And then the facial hair, yeah, I feel you. I already have to wax these little hairs under the chin, and now my grandma, she's 91 and she gets a lot of them. So There's not something that we give for that unless you're going to go see a dermatologist and have like electrolysis or laser therapy, and you want to have that done before the hair turns gray. And yes, you can get gray hair not only in the chin area, but also in the genital area. People are surprised. They're like, oh my goodness, I didn't know I could get gray down there. Yes, you can. But it's not harmful. It's just a reality of what happens as we age. So yeah, those are the things that you can try. There is a cream that can be used. I think it's called Vaniqua for hair too on the chin. I've never tried it, but those things, they're all temporary, you know, and once you stop them, you can get the hair back. For women that are in perimenopause, they're not quite in menopause yet, you can use birth control, the type with estrogen, and that can help with some of the hair, but it's not 100%. And some of it's based on your family history. So if you see Aunt Jeannie, who has a ton of hair, you know, under there, and she's older, then that may be your fate too. So some people will get that area waxed, or they'll shave, or they'll pluck to remove the hair. Okay, here's another message. I'm over 50 years. I am on receiving monthly period, and it's not regular. I can miss 1, 2, sometimes 5, 8 months, and then comes back. But what is bothering me much is the bleeding is very heavy, back pain, and my stomach is big. I look like 7 or 8 months pregnant. Please help. Okay, so it is normal for the period to skip around 50 years old. And it sounds like this person has not had the 12 months, as we discussed, 12 months in a row. So this person has gone even 8 months, and then she's had to start over again with her clock. So she's not in menopause yet. So it's very frustrating because this period is coming and going. But the other issue is this heavy period with the back pain, and then her stomach looks large. And what that could mean is that you may have fibroids. I'm not for certain. So fibroids are tumors of the uterus. Usually they are not cancerous. They're very common in women. And they can grow over time, and they can get very large to the point where you look like you're pregnant. That is one of the things that could be going on. And they can cause pain, and they can cause heavy bleeding. So that would be my first guess. But you would need to see your doctor so they can do an ultrasound to take a look. And then once they see if they're fibroids or not, then they can offer you treatments for it. Usually with fibroids, if they're causing not only bleeding, but if they're causing pain and like pressure because they're so big, then we offer you treatments to try to shrink the fibroids. And there are procedures that can be done besides hysterectomy. Hysterectomy just takes the whole uterus, but there are other procedures now that are less invasive that can just target the fibroids to reduce their size, which then can help with the heavy bleeding and the pain. But first you need to know what's going on. So I would definitely say you need to get in with your doctor as soon as you can to confirm whether it's fibroids or is it something else that is causing your abdomen to be large and for you to have those symptoms. Does breast size determine the risk for breast cancer? No, the size doesn't. There are other risk factors like whether you've had a baby or not, whether you breastfed or not, how early you had your period, what age, and then when did you have menopause, your weight, your overall weight can be a risk factor, and other medical conditions, and of course, family history. Please share the meaning. Oh, okay, that's that. Okay, can you speak a bit about the BRCA gene? Do you recommend women be tested for it? So BRCA is one of the breast cancer genes, meaning that if a woman has BRCA, they inherited it from a family member. It runs in families. There's BRCA 1 and 2, and the difference is one of the differences, like if you have 2 versus 1, you'll have a difference in your rate of ovarian cancer or breast cancer. But there's other cancers associated with the BRCA genes, like skin cancer. I think one could be pancreatic cancer. And then there's ovarian cancer and breast cancer. So, but these are not the only genes that are associated with breast cancer. So these days, they run a full panel. There may be like 17 genes or more, I've lost count, that can be associated with breast cancer. So that's why for somebody, we don't test everybody for the BRCA gene. we first screen you by checking your family history. So we want to know how many people have had breast cancer in your family. Are these close relatives or far away? So if it's a great grandmother, we're not as concerned. But if you say your mom, your sister, and your mother's sister, your maternal aunt had breast cancer, well, I'm concerned. And so I'm going to send you to see a genetic counselor, and then they're going to calculate your risk of breast cancer. And if it's 20% or higher, then we're going to offer you MRIs of the breast, MRI test of the breast, in addition to mammograms. And then they're also going to offer you breast cancer gene testing. But usually what they like to do is if you have a family member that has breast cancer, they want to test the person that has the cancer if they're living, because if they don't have a gene for breast cancer, a gene that's been identified that can cause breast cancer, then there's no need to test you for it, because then we know that their breast cancer wasn't due to one of the genes that we know causes breast cancer. So usually we try to get those family members involved. Now, sometimes it can be challenging because patients will tell me, oh, the family member lives far away, or we don't talk anymore, or what have you. So if you can't get those people involved, or they're not willing to get the test, then sometimes the genetic counselor will have the patient themselves who hasn't had cancer get the gene testing if their family history is strong for breast cancer. The other thing that we look for is the age that the person had the breast cancer. So let's say you say, okay, my grandma had breast cancer, but she was 90. Okay, that's not as concerning as if you tell me, well, my sister had breast cancer and she was 40. Okay, under 50, we get concerned. And we're like, now that sounds more like it could be related to a gene, and we may need to send you for genetic counseling, and hopefully your sister can come too, or she can give us information about whether she's had gene testing or not. What would you recommend for fibroids? Please give and highlight on hysterectomy and myomectomy and other options. So fibroids, yes, as we were discussing, they're very, very common. They can cause pain, they can cause heavy bleeding. And some women, they don't cause anything. So some women, you know, we'll find them. We're not even looking for them. We're looking for something else. And we get an ultrasound, we happen to see fibroids. And then sometimes women are very concerned about them, and they're wondering, are they going to grow, or do we need to watch them every year, or what have you? If you're not having problems with them, we don't have to follow them that frequently with an ultrasound every year. But if you are having problems, then we have to determine what the problem is. Is your main problem the bleeding? Is your main problem the pain? Or is your main problem the pressure? Because each symptom, we offer something different. So let's say your main issue is the bleeding. Then if your uterus isn't too big, we can offer certain hormonal therapies. So there's, you know, we can use birth control to help with fibroids and heavy bleeding. We can use an IUD, the Mirena IUD can be used to help with it, as long as the uterus isn't too big, and as long as you don't have a big fibroid sitting where the IUD needs to go, because that goes in the uterus. There's also a non-hormonal medication called tranexamic acid. The brand name is called Lysteta, and that is non-hormonal, it's not birth control. You use it just during your period. You can use it whether you have fibroids or not. It's for heavy bleeding. And you take 2 tablets every 8 hours for up to 5 days. You can't take it beyond 5 days. So if your period lasts longer than that, you can't take it longer than that, but you can take it up to 5 days. Again, it doesn't prevent pregnancy. So this is good for people that are trying to get pregnant and they don't want to use birth control because they're trying to get pregnant. Or somebody that just says, I don't want to use birth control. I don't want the side effects and this and that. And that's fine. Then they can try this medication, and it's been shown to help lighten the bleeding. And you can just keep using it. People that can't use it are people that have ever had a blood clot in their leg or lung, but that's not very common. In addition to some of the medications we use for fibroids, there are procedures that can be done to shrink the fibroids. And those procedures can be used for women that have painful periods with the fibroids, heavy bleeding, or just pressure. Like they can actually feel like it's a bowling ball sitting in there because the fibroid is so large. So one of the procedures is called a uterine artery embolization, and we shorten it and we say UAE. So the way I describe it to women is, well, first of all, a radiologist does it. So not the OBGYN. So we send the patient to see the radiologist and they do it. And what they do is they put a catheter into your groin, and then they put little particles in that catheter to try to cut off the blood supply to the fibroid so it shrinks. So an analogy that I like to use to make it easier for you to understand is, imagine you have a garden hose, something you're using to water the grass with or water your plants. If you put sand in that water hose, the water's not going to get to the plants or to the grass, and then whatever you're trying to water will die. So that's how that works. They're putting the particles, they're medical grade particles, they're put into that catheter right into the arteries that are feeding the fibroids, so that the fibroids aren't getting fed anymore and they die off. Now, you can't use this type of procedure if you're trying to get pregnant, because we don't know the outcomes in women that have this procedure and then they get pregnant, because you're affecting the blood supply to the uterus. So it's not recommended for women if you're not done with childbearing, but it can help to reduce the fibroid size and reduce the amount of bleeding. There's also other procedures that can reduce the fibroids. Another one, they do it in the operating room and they use a probe to try to, they put it right up to the fibroid to try to shrink it. And there's some other specialized procedures where they use like an MRI and ultrasound outside of your body to shrink the fibroids. But usually that's done at a specialized center. It's not done at our hospital. So you'd have to go to like a university hospital. So like in our area, it'd be like the University of Michigan. And so you would have to go see a specialist for that. Myomectomy is where they go in and remove the fibroids. It can be done abdominally, meaning that you have a cut, almost like a C-section cut on your lower abdomen, or it can be done laparoscopically. And that means where we use a camera and small little incisions to go in and remove the fibroids. For that type of procedure, the laparoscopic one, you would need to see someone that's very specialized in that, who's done a lot of those procedures and feel comfortable with it, because it's not easy, but your healing time would be faster if you can see someone that can do it that way. But the myomectomy is used for women that want to keep their uterus and maybe they're considering having children. But if you're done having children, usually we say if you're going to have someone go in there, you might as well take the uterus out than just take the fibroids, because the fibroids can come back 50% of the time. And then the risk of the myomectomy is the same as the hysterectomy. So you should just get it all done if you're done having kids. But so we reserve the myomectomy mostly for people that want to have kids and they want to keep their uterus. The other medication that's out, there's one called Orion. And that one, it can help to shrink the fibroid and help with the pain. It's almost like a birth control, but not. So I can't tell you that it prevents pregnancy, but it uses a medication that kind of shuts your system down. It puts you in a menopausal-like state. And that's what kind of shrinks the fibroid. And then it has a little hormone in it to try to offset those menopausal side effects like hot flashes and vaginal dryness. I haven't used that one in patients yet, but it sounds like from the reports that women have experienced some relief, but I don't think that you can use it long-term. So that's the thing. So far, I've seen where people have used it for about 2 years. So that's kind of like a little highlight about fibroids. And that's a very common topic that we deal with. And we see a lot of different women presenting with different symptoms with the fibroids. Another thing I would tell women regarding fibroids is to watch your diet. Watch processed foods and a lot of red meat. You know, the red meat has a lot of hormones in it, and the hormones can, those estrogens in there can feed the fibroid. So you may want to try to cut back on those types of things. And I've been looking into trying to use some essential oils to try to help with the fibroids as well. And so that's something you can look into as well. I think we've gotten through the questions in the chat. Are there other questions that you've thought about?
Yes, I have a question here that I had written, and I know the women had asked the other day. So I read depression is the most common health problem for women. Would you agree with this statement? And if so, what is OBGYN field doing to help women with depression?
Yeah, depression is very common in women in general. Now, OBGYNs do not, we can diagnose depression in some women. Most of the time we will diagnose it for postpartum depression, but a lot of times we're giving women resources of counselors that they can see or psychiatrists that they can see to manage their depression, because we are not, that's outside of the scope of our practice to try to treat depression. So sometimes patients will want us to manage their medications for depression, and we have to defer that because that is not part of our training. So our main goal is to identify when someone is depressed through screening. We try to quantify the magnitude of the depression, meaning when's the last time she had suicidal thoughts? Has she ever tried to commit suicide? And what's her home situation like? Does she feel safe at home? What does she think her triggers are? And where is she at right now? Like, is she stable in her mind right now? Or does she feel that she's going to harm herself or someone else? And then from there, we're able to direct her to the resources needed, because oftentimes it is the OBGYN that sees these women first, or primarily. Sometimes we're the only physician that the women are seeing, especially at a young age. So they look to us for resources. So sometimes we have to give them the suicide hotline. Sometimes if it's a domestic violence situation, we're giving them resources for that. Sometimes they need community resources because the depression is from the lack of resources, the lack of having a house, the lack of having, food. So we provide those resources. We have a community bank or a community book where we can provide resources. And so it really depends on where that woman is, and then we try to direct her from there. And then we try to touch base with her. So if we're really concerned about somebody, especially if it's postpartum, we want to touch base. We want to have a follow-up visit to make sure that they have made the appointments that we have suggested, and to make sure that they're starting to feel better. So that's where we play a role.
Thank you. Another question. Suicide is a leading cause of death for women under 60. Is that so?
Can you repeat that question for me, please?
Suicide is a leading cause of death.
So depending on the age, yes. So at a younger age, the younger age group, we are seeing that suicide is a cause of death for women. However, most of the time it's the men. So women may have suicidal thoughts and they do commit suicide, but it's the men that actually carry it out. So women may try it, but the men actually are succeeding at it. And so thankfully, I haven't had a lot of patients that I know of who have committed suicide. However, we try to intervene well before they commit suicide, to get them the help that they need, and also to help them to identify those triggers so that they'll know when to call if they need help. Oh, there's something else in the chat box.
Thank you. There's a question there.
A caller requesting you to advise on how to come out of pre-diabetes to normal blood sugar and best and healthy way to lose weight for a busy woman. Yeah, that can be challenging. So I was at a conference recently, and I was talking, I listened to one of the lecturers who helps with weight loss. And she was reminding us that there isn't one way for someone to lose weight, meaning we can't just tell everybody, eat right and exercise. I mean, yeah, that's part of it, but some people have some metabolic things going on, some imbalances that sometimes need to be addressed to help them with their weight loss. But in general, I would say to make sure you're having a well-balanced diet, you need to watch your portions. So sometimes I even use the little cups for portions, because when I try to just eyeball it, I'm like, oh, that I put much more pasta in my bowl than I should. Do you know, like a serving of pasta is like a half a cup, and who wants that for spaghetti, So, but using portion sizes or portion cups or containers, which you can purchase probably online, is very helpful, because a lot of times we're eating too much. Now you may say, well, I don't eat a lot. But then we have to look at, well, what are we eating? What's the composition of the food that we're eating? How much protein are we getting? Sometimes we're not getting enough protein, and we're getting too many carbohydrates in our diet, meaning we're eating too much of the bread, rice, pasta, and then we're getting too much sugar in our diet. For the American diet, there's so much sugar in everything. And so there's sugar in these, if you're a busy mom, you may be stopping at Starbucks. I don't know if you're getting those coffee drinks, those $5 coffee drinks are full of sugar. So you want to reduce the sugar in your diet however you can, and even watch the fruit, because there are fruits that are high in sugar. And so fruit is good, but you don't want to have too much. You want to follow the portion sizes. And that's why I think those portion cups are good, which requires some meal prepping and meal planning. So I'm not a mom, but I am very busy. And so, but I do try to watch my diet because I have diabetes in my family and I am at risk. And so sometimes I get hypoglycemic, so I have to eat like a diabetic, which means that I have to plan it out. So I may start off with an apple and some almond butter. So there's your carbohydrate and there's your fat and your protein in the almond butter, rather than having a bagel with cream cheese. You know, that's not going to help me as much, or a donut. So I have that apple. Then I may have a protein drink that I drink with, but I make it at home because some of the protein drinks that you buy are full of sugar. You have to wash that. And so I'll use almond milk or coconut milk rather than dairy milk. And then I have the protein drink. Sometimes I'll add a little fruit. But lately what I've been trying to do with that fruit is use my portion cup, because I find, again, when I eyeball the fruit, I'll put more in there than what I should, and that's increasing your calories. And then you want to make sure that you're getting a lot of green leafy vegetables. You need enough fiber in your diet. You have to make sure you're eliminating appropriately and drinking lots of water. Sometimes we don't drink a lot of water. And when you're feeling that hunger, sometimes it's that you're dehydrated. So we should be drinking half of our body weight in ounces. So let's say you weigh 200 pounds. You need to be drinking 100 ounces of water every single day. So it's all based on your weight. And oftentimes we're not getting enough water. You can meal plan. I know you're very, very busy. But if you just sit down when you can and say, okay, these are the meals we're going to have for the week. You know, a few you can cook, a few you might want to buy out. And that way you're not coming home after a busy night trying to figure out, well, what are we going to eat? Well, let's just get pizza, you know. So you got to think a little bit ahead about what you're going to eat. Detoxing is very important. There's a lot of toxins in our bodies that can hold on to fat. And so doing a healthy detox can be good. There's plenty of ways to do that. And exercise. So we have to burn more than what we're putting in. So if we're not moving enough, then we're not going to burn those calories. And so people will tell me, oh, well, I get enough running around after the kids, or I walk a lot at work. And I'm like, I walk a lot of work at too. I mean, I'm up and down the stairs and all over the hospital. However, I had a trainer tell me a while ago that that's not enough. Like, that's great, but that's not enough. You need at least 20 minutes of sustained exercise at one time. And so when we're running around after kids or walking at work or whatever, we're walking and stopping and walking and stopping. But if you could do 20 minutes of sustained movement, that would be good. And your goal should be 30 minutes, 5 days a week. So that's kind of a lot. That's a big goal for somebody that's very busy. But I would just say work on keeping moving. So even if you can't get that goal, try to be creative in your exercise. So sometimes at lunch, if I get time, I'll go out even for 10 minutes. I'll say, okay, I got that in. And then you could keep gym shoes in the car. And if you get a minute right after work or wherever you are, and you could just walk around the building a couple times before you go to your next place, that's getting your steps up. Because they say we should get 10,000 steps a day. And I don't think I'm getting that, but just trying to set realistic goals for yourself. And then you have to sleep enough, because not getting enough sleep affects our hormones and our cortisol levels, our stress levels, and that puts on weight too. So there's many factors that affect our weight, and you may want to work with a trainer if you can, or a nutritionist. There's online coaches, there's Weight Watchers. Some people do that, and that helps them with their portion control. And getting involved in groups, exercise groups can be helpful just to encourage yourself. So those are some of the things I'd recommend. There are weight management specialists that you can see that are doctors who have studied this, and you can get involved with them too. But it's not an easy answer, and it's not a one-fits-all kind of plan for everybody. So you'll have to find the plan that's going to work best for you, but sometimes you need the assistance of others who are specialized in that area. No, okay. Someone asked about the HPV vaccine is 100% effective in preventing cervical cancer. No, it doesn't cover every single HPV type, and there's many different HPV types in the world. It covers the most common types, and if you have already been exposed through sexual activity to a certain type of HPV before you decide to get the vaccine, then it's not going to be as effective. But in general, it's not 100% effective, because it's not protective against all types of HPV. Going back to menopause, please explain the relationship between hormonal changes and heart disease. You know, I don't know all of the physiology offhand, but I can tell you that there's you have a reduction in your estrogen, and it's the estrogen that helps with the heart. But the thing is, at this point, they're not saying to automatically give everybody estrogen in menopause to try to prevent heart disease, because there are other risks by using estrogen in menopause. There's benefits, but there's risks. So we're not to the point where we can say, oh, to prevent heart disease, we're going to give everybody estrogen. So that's why you need to do those lifestyle changes. And it's best to do them now before you get into menopause, unless you're there now, so that you can get used to it in terms of the exercise and enough water and not smoking and reducing red meat. I mean, if you're having red meat, you need to reduce that to just twice a week. Not having a lot of saturated fat. So the cookies and the cake and the stuff with a lot of butter and things with a lot of fat, fried foods, you know, switch to baked and try to have more fish. Those things can help you with your heart health, and having grains, whole grains and fiber and green leafy vegetables. But it's something with the estrogen and you get a decrease in estrogen when you're in menopause. And that is likely what the changes are we're seeing with the heart. Good questions. You guys are good. I appreciate all of this discussion. I like it. I think it's easier and more interesting if I address the questions you have than to just talk about a random topic, because then I don't know if I'm addressing your questions or not. So I like this format and I appreciate your participation.
Thank you. I appreciate you as well. Any other questions? I don't see anything in the chat. You can unmute yourself if you have a question. If not, I'll ask you, Dr. Frost, is there any other items you have out there, something you want to tell us as women?
I would say, don't be afraid to put yourself first. It's not being selfish. Women are in a position, whether you're married or single, divorced, whether you have kids or not, you know, we take on a lot of things and we can handle a lot of things too. But oftentimes in handling all those things and helping all these people, we are overlooking ourselves and our need to rest, our need to eat properly, our need for enjoyment. It's okay to go and do something fun for yourself. And so please pencil yourself in to your schedule each day. Schedule yourself, prioritize yourself before you're prioritizing everybody else. It doesn't mean that you're going to be selfish and you're not going to help people, but you cannot be a help to others if you don't take care of yourself. So don't feel guilty if you need to tell someone, no, I can't do that. You know, that's my time to rest. Or, no, I need more time to exercise, and I'm not going to be able to commit to that, you know, because again, I find this with all women, even myself, that we have a hard time balancing and prioritizing ourselves. But just try to set aside time to rest, to read, to take a walk, to just enjoy nature, to spend time with God. And don't overlook yourself. Don't overlook your health. Make sure that you get in and get those preventative visits in. Don't, some people will just wait. They'll have all their kids and then they say, oh, I haven't been to the doctor in 15 years. So they've been taking care of everybody else. But don't overlook yourself. You're very valuable. You're precious in God's sight, and He wants you to see yourself as such and to take care of yourselves. So that would be my word to you today.
Thank you. Amen on that. Appreciate you. I just thought of a question when you were talking to us. I thought, for example, myself, if I could give an example of myself, since I stopped childbearing age, I stopped, and my doctor, my PCP, she does both the pap smear, and she sent me for mammogram. Would you recommend to still see a OBGYN?
So in that case, if the primary care doctor does all of that, does the breast exam, in addition to sending you for the mammogram, and does your pelvic exam. So if you still have a uterus, if they're looking below and doing all of that, then you don't have to see an OBGYN. And I have patients like that. So sometimes the primary care doctor will do everything, and then they'll just send the patient to me if there's something beyond that that I need to address. So that's a good question.
Thank you. At what age, for those with girls, would you recommend them bringing them over to OBGYN?
That's a very common question as well. Usually I will say that they can continue to see their pediatrician for as long as they will allow. But if the young lady is having trouble with her period, or has other questions about birth control for the future, or things that the pediatrician is unable to handle, then they can see me sooner. So there's not an exact age that they have to come. Our OBGYN association says that they should at least touch base with us around 13 to 15 years old. But in real life, we're not seeing that. And it's really not necessary unless they're having problems that we need to address. So if they're not having problems, then usually I start seeing them around 18, 19 or so when their pediatrician stops seeing them. And then I also encourage them, though, even women in their 20s, I encourage them to have a primary care doctor in addition to the OBGYN, because let's say they have an ear infection or back problem or, anything else that's not related to OBGYN, they're going to need a primary care doctor too, in addition to us.
Perfect. Thank you so much. I know I had another question. Anyone else out there? So I don't dominate this meeting.
Yes, I would like to ask, what would you recommend for those who are post-menopause?
For those who are in menopause?
Post, I guess, over.
Postmenopausal?
Yes.
So making sure that you are exercising, it's very important to stretch, make sure those muscles stay nice and flexible. So stretching every day is great. Making sure that you're getting enough calcium and vitamin D for your bones. So you can get that from your food, but then you can supplement some with that, because that'll help keep you from having a fracture or a break of one of your bones. I would encourage you to still do things to stimulate your mind, whether you want to read or do certain puzzles, things like that, so that your mind can stay active. And then still continuing with some of the screening. So for the Pap test, usually the screening for cervical cancer, if you've had multiple screenings through the years, and some close to age 65, sometimes we will stop after age 65, but usually we'll talk to the patient and review the records with that. And then for mammograms, sometimes we'll continue into the early 70s, but sometimes we continue beyond that time, depending on how well the patient is doing and their life expectancy. And then another thing we didn't talk about that's important around that time is colonoscopy, colon cancer screening. Now, we used to start at age 50. Now they're saying to start at age 45 for African Americans or those of African descent. It's recommended definitely at age 45 because we're at higher risk for colon cancer. And by 50, for sure, we're doing those colonoscopies, but there's other screenings that we can do besides colonoscopy for colon cancer. But at some point you need a colonoscopy. But at some point down the line, we stop doing those, at later ages of life. But that's another very important screening tool. The other thing I think about as I think about my grandmother, she doesn't drink enough water. She's 91 and she gets dizzy all the time. You're smiling. I see you over there too. That's Miss Mary. You might not drink enough water either. She said, I'm dizzy. I say, Grandma, how much water have you had? And then she'll say, I just had a little bit of this. And I say, Grandmother, for the whole day, I say, you need to have, now for her, I don't require her to have half of her body in ounces, half of her body weight in ounces for water. I say, try to drink at least 2 of these bottles a day, because she barely drinks one of these, okay? Try to drink 2. And then she says, well, but I have to run to the bathroom all the time. And I say, I know, but if you're dehydrated, you're going to be tired and you're going to feel dizzy. So try to drink more water if you can. That would be very helpful for you. And enjoy life.
Thank you.
You're welcome.
All right, any more questions?
Oh, thank you, Dr. Mary.
I'm also thinking while someone else is coming up, I'm thinking about the mammogram. Nowadays, when you go, the doctor, they will ask you, do you want do you want, I guess, the ultrasound or something, or the 3D?
Oh, yes,
What's the
yes.
difference? Okay.
So, before 3D came out, we had what was called a 2D or the digital mammogram. And so that was good for that time, but you know, times have changed and technology has advanced. So the 3D mammogram can see better, a better visual of the breast all around than the regular digital mammogram. Now, these days, it seems like the insurance is starting to cover the 3D mammogram. Initially, we were having some trouble, but it seems that it is. But for some patients, they still have to pay a little extra. So if your insurance doesn't cover the 3D, don't fret. Just go ahead and get the regular one. It's better than not having one at all. But if you can get the 3D, we suggest it. And it's especially beneficial for women that have dense breast tissue. Remember the dense, the compact tofu stuff that's in there, because if you have very dense tissue, then on a mammogram, that's going to just look like a big snowball. And then how can you see a mass, a breast mass in the midst of all that dense tissue? So the 3D can help. But in addition to that, there's another test that has come out. It's not considered screening, but it is something that you can use in addition to mammogram, especially if you have very dense breasts. It's called an automated whole breast ultrasound. Not every center is doing it, but our hospital is doing it and certain centers are. So you can check in your area. And what it is an ultrasound of the whole breast. Instead of just one little area, it checks the whole breast, both sides. And that's especially useful for women with dense breasts because then it can see beyond that dense tissue and it may be able to detect a breast cancer in those cases, even before the mammogram will be able to see it. Now, insurance doesn't consider it screening, so it may not be free. So I went and had it done because I have dense breast. And so I wanted to be able to tell the patients what it's like, you know, and how much it is. So with my insurance, it costs about $200. And so you'd have to check with your insurance. If you don't have insurance, I wouldn't get it because it's going to cost too much. And some of those programs that help assist patients if they don't have insurance may not offer it yet. So if you can't get it, it's okay. But if you have the opportunity to get it, you may want to look into that if you have dense breast tissue. If you have mainly fatty tissue, which they can tell by the mammogram what you have, then you probably don't need that.
All
so
right.
thanks for asking about that.
On that question, thank you for the responses. You're awesome. Talking about that same on mammogram. So let's say, like I know families where there's family history of breast cancer. And what do you do, or how do you advise the younger ones? Let's say, for example, I know this family that their daughter just died last year. I want to say she was 32 or 34, that age, and she has younger siblings. So how do you deal with that as OBGYN with the siblings?
Yeah, so what we do is we find out the age that the person who had the cancer, what age were they diagnosed? So let's just say that person in the example you gave was 30 years old when she was diagnosed. Then let's say for her sisters, that's a first degree relative. We will want to start screening them 10 years before the age that the person with the cancer was diagnosed. So in this example, we would start screening them around age 20. And the screening may look different because, you know, mammograms are kind of hard to do at age 20. The tissue is so dense. So we may start with breast exams in the office and ultrasounds. But sometimes we will start the mammogram even as early as age 25. Usually in these situations, especially when we're dealing with such young people, we will send them to see the genetic counselor so that then they can be screened for their risk of breast cancer to see, do they also need an MRI of the breast? Because we would start that too. at a young age. And then if we did not know if the person that had cancer, if they had gene testing or not, then we would offer genetic testing to those siblings to see, do they have a gene for breast cancer? Because at that point, if you have a gene for breast cancer, like, and I think that Sarah was asking about BRCA, what I didn't talk to you about is at some point, once you're done, usually around 40 or so, we will recommend getting a mastectomy, taking the breast off, you know, to reduce the risk of breast cancer, because the breast cancer risk can be very high when you have a gene for it. But that's a big decision for women to make, to remove the breast, but some are becoming more proactive with it. And they're like, you know what, just take them off because I don't want to, you know, develop breast cancer. But then we also have to look at ovarian cancer risk with certain of these genes. And so then sometimes we're offering birth control to help reduce the risk of ovarian cancer. It can reduce the risk by 50%. And it doesn't seem to increase the risk of breast cancer because we always want to weigh that out. But at some point, which we didn't talk about with the BRCA gene, once you're done having kids, we recommend taking the tubes and ovaries out because the risk of ovarian cancer is high. So there's a lot of counseling that takes place when patients have family members with breast cancer that are their siblings, and it's occurred at a young age. And that's why we use multiple, we call it a multidisciplinary approach, meaning we use multiple doctors to help. So we have the genetic counselor involved. Then usually we get the breast surgeon involved because they deal with breast cancer. And so they talk about when is it time to have the breast removed or not, or to do it at all, and what type of breast cancer screening they need. Sometimes we get the oncologist involved, the breast cancer specialist, because there's medications that people can take if they're older, not the 20-year-olds, but if they're older, that they can take to reduce their risk of breast cancer. So it is a whole planning event. We have a lot of people involved as we're trying to counsel women and help them and guide them when they have this strong family history of breast cancer.
Thank you so much. And I know it's expensive, and and many people that may not have insurance. And I also have seen it in the insurance, having worked in an insurance industry, that the insurance denies those claims.
Mm-hmm.
And so I know most of us, I don't know whether it's anyone else from another state, but for those who are from around this area in Raleigh, I think it's called neighborhood clinic right there on Blue Ridge. They have a OBGYN that can help with what you may have, follow-ups. And so, I would recommend them for someone without insurance because they are low income, or I guess they weigh your pay according to your income. So just wanted to throw out there for any woman that may be in need. Thank you.
That's very
Any other
important. Very important.
Any other questions?
I'll say this too, make sure you're taking your vitamin D. Everybody needs vitamin D. We're all low in it. And they do ask, people say, oh, well, I can make it from the sun. Well, people that have a brown skin, whether you're African-American or African or another ethnic group, you don't make the vitamin D from your skin as well because of the melanin in the skin. Caucasians can make the vitamin D from the skin just with 10 minutes of sun exposure. But then think about the winter time, wherever you're living, I'm sure it gets dark earlier. And so we all need vitamin D at some point. I would say you could start off with 1,000 to 2,000 international units IU per day. It's very hard to overdose on vitamin D. And you can even have your doctor check your vitamin D, but most people are low as it is. And there's food sources for vitamin D as well. And they say that in addition to it helping with your bones, your immune system, and your possibly breast health, that there may be some link with multiple sclerosis as well. So for those of us that live in northern climates, like I'm in Michigan, it's very important for us to get that vitamin D. So make sure you do that. And it's fairly inexpensive and readily available.
Thank you. Thank you so much. I think someone has a question.
Yes, it's me again. My question is, what could be the reason why my hair gets thinner and brittle?
There's different causes for that. Some of it can be vitamin deficiencies. And sometimes we see that if your iron is low, but you don't want to just start taking iron without knowing for sure if it's low. A natural source of iron where you probably wouldn't get, overdose on it would be blackstrap molasses has iron. If you can find that at the grocery store, and take a tablespoon of that. Sometimes the vitamin D is low, so that can affect the hair. Sometimes it's the products that we use in our hair or the water. Sometimes the water is too hard in the area. And then sometimes there's certain conditions that cause the hair to become thin, like our thyroid, this gland right here. Sometimes there's disorders with that can impact it. So if you are able to see a doctor, I would talk to them about it and they can do some tests to see if there's any vitamin deficiencies with the hair. I know there's vitamins out there, there's hair, skin, and nails, and all these other vitamins, but sometimes you're getting too many vitamins. So sometimes we think more is better, but that's not always the case. And certain vitamins can impact our lab results. And so you may want to talk with a doctor if you have access to one to let them start looking at the hair. If you have a hairstylist that you trust, you can let them look too, because sometimes my hairstylist diagnosed something for me, and then I had to see a dermatologist. I had lost some hair in the back, and that's called alopecia, which is bald in one spot. And they found that was from stress. But I did have to go see a dermatologist and apply creams and stuff to that area. So sometimes there are medical things going on, and sometimes it's nutritional or a combination.
Thank you.
You're welcome. So are most of the people here from North Carolina area or anyone else from outside of North Carolina? Mostly North Carolina. Well, it's a nice state. I've been there before. I've been to the Charlotte area and Asheville area and Black Mountain. I haven't been to Raleigh, so we'll have to come there one day.
It's beautiful. You need to move here.
Oh, move there. I just had a friend move there, actually. I have to remember what city.
We all will be your patient.
Oh, someone just asked, do you think over-the-counter vitamins are okay? It depends. Some of them are junk. They're full of just fillers and just foolishness. I like to buy vitamins from the health food store, and I like certain brands, but and then it can get a little complicated. Like I learned from my chiropractor that not everyone responds to the same vitamins. So there's something called muscle testing that you can have done, but this is kind of specialized. It's not very, I don't think it's very expensive, but you have to find a chiropractor that can do it. But you can take your vitamins in and they can, move the vitamins around your body on the outside and do certain tests to see how your body responds to make sure that vitamin is good for you. I've done it before. I'm not going to say it's a requirement, but yeah, you have to be careful with the brands of vitamins because like I said, some of them are just junk and they have a lot of additives in there. But if you get some of the ones from like a health food store and you can talk to the employees there, they know some of the more reputable brands. I like Garden of Life vitamins. I like Ancient Nutrition. Some of those are good. But some of the other ones, no, they have like red number 5 and blue number 7 and, all those dyes in there. And you don't want to take a vitamin and then you're adding more toxins to your body too. So you do have to read the labels. That was a good question. And yeah, you do have to be careful with natural things. I like to use both. I've used traditional medicines and then I do like holistic things. But even with the holistic side, there can be side effects. You have to be careful. You can't combine certain herbs with other supplements, and there can be side effects of bleeding and things. So don't think just because it says it's natural that there's no side effects or that there's no toxic effects. There are some that can cause toxins to your liver, toxic to your kidney. So you really have to be careful, and you may have to work with somebody that knows about these things, like an herbalist or somebody that's into complementary and alternative medicine. Because I don't want you to think just because it's natural that you can't have any bad side effects.
Thank you. We are winding up. Any other questions?
Looks like someone's talking, but I can't hear him. Or maybe not. The lady on iPad 2. Were you trying to speak? The lady with the pink hat and the light blue top?
Lydia, you are muted.
Yeah, we can't hear you, but I don't know if she doesn't look muted.
Mm.
Can you type your question in the chat box? Because we can't hear you. And you can put it in the chat and we can read it. Oh, okay.
While she's typing, I would like to comment that personally, when I'm buying vitamins, I would prefer the ones which have the good manufacturing practice label on it, or USDA, because some of the vitamins do have claims that are not consistent with the content of the tablet.
She's absolutely right. That a lot of them haven't been studied, and they can just say, you know, may help with this or may help with this, and that it may not. And then they're just taking your money.
Okay. Did anything get left out? Anyone out there with any other questions? If not, I want to take this opportunity to say thank you so much, Dr. Frost, for your time. I mean, even all the time we have had this session, I don't think we haven't had so much time and free time to ask whatever, and to be just women, you know, and it's just such a good feeling to feel like a woman, to be with women and just talk without thinking who is on the other end of, you know, our conversation. So we thank you so much, appreciate you so much. When I requested you and you said you were even open up to 3 hours, which is where we are heading now, that was, I mean, I couldn't even believe it. I wanted to ask you, did you say you could do this and for nothing, for no pay, and yet you could have been making money or doing something, you know, could have been, you know, working out there. Or just resting. I mean, you told me you work 24 hours. So sometimes you're on duty 24 hours. So I'm sure you'd have enjoyed, you know, just having a resting time. But just to take this up, just to take the time off away from your time off and be with us and be such a blessing. We want to say thank you so much. We appreciate you. We honor you for your time. When I was looking through your stuff, I realized you also have been to Kenya. Quite a good number of us are from Kenya.
Oh,
So
Jumbo. Oh, I enjoyed Kenya and Uganda.
okay. Yeah, I'm sure. I don't know when the last time you were there.
It's been some time. I was in Uganda in 2020, just before everything hit with COVID, but I was in Kenya. That was 2003. So we were planning to go last year, July, and take a group who hadn't been in a while, and then we had to cancel the trip. So, oh, we'd love to go back to Kenya, though. It was great.
Oh.
Absolutely beautiful.
Yeah, it is, and it's changing a lot, and trying to catch up with the Western world, which kind of, in one way, is not good.
Right. I believe that.
So we thank you. I want to thank these ladies. The invitation came at a request of a group of women from remind me, URBC, United Brethren, I forgot how they say, but it's UBRC. It's a women department. So that's the word I've been looking for. It's a women department that requested that they have a women doctor talk on one-on-one, and I want to take this opportunity to thank them, and even just taking their time away to come and participate to educate all of us and other women around the world, because this program goes to, it's not only here with us, but also there's someone who may watch it tomorrow on Facebook, and I'm sure it will be a blessing to many. So we are thankful. And again, thank you, Dr. Frost, for your time. When you're going to Kenya, you're going to tell us so we can.
Yes,
we can take you around.
That would be great. Get some Kenyan tea.
Yes, yes. Yeah, when you're talking about caffeine, that is where we get our caffeine from the tea.
Yes, I know.
Yes, yes. So thank you so much. For those that do not know, Dr. Frost, she's very busy. She's not only an OBGYN, she's also a chair in a Christian Medical Dental Association for Women in America. So we have a very important person and someone who is very busy herself in our midst. And to end, if there's no one else with a comment, I'll ask, maybe, do you mind, Dr. Frost, praying for us as women? I feel like you have that anointing with you.
Sure, thank you. And thank you all for having me. It's been an honor and a privilege, and I really had fun with you. So thank you for being so interactive and asking great questions. Dear gracious and heavenly Father, Lord, we just thank you and praise you for this day. We thank you, Lord, for life, for health, Lord. We thank you that you created us, and we thank you, God, for Miss Eva, who is working as your hands and feet to educate women and to provide resources and provide educational opportunities such as this. Lord, continue to bless her, continue to keep her healthy and whole, Lord, and continue to send her people her way to help her with this endeavor, Father, and protect her, Lord. We thank you for all the women that are involved here behind the scenes and before, Lord. Just continue to bless them, Lord. I pray a special blessing over the women here, God, that their minds, Lord, will be at peace, God, that they would be whole from the top of their heads to the bottom of their feet, that they would not have anxiety or worry, and that they would take time to prioritize themselves and to rest and to refresh and to allow you to just love on them, Father. I pray, God, that you would bring deliverance in their families, Lord, with whatever is going on, that you would bring deliverance for them with their resources, their finances, God, that you would bring deliverance in every area of their life. And most importantly, that they would sense your peace and your presence with them now and forevermore, God. So I just pray, God, that you would connect them with the right healthcare doctors, with the right counselors, with the right people and the right plans and the right medicines and the right nutritional things, Lord, because you know how their bodies are made and you know exactly what they need, Lord. And we pray against any harmful effects of toxins in our environment or from anything that we're ingesting from affecting our bodies, God. And I just speak health and wholeness over their lives and over their bodies, over their minds and the emotions, God. And I just pray that they will walk in your peace and your joy this day, now and forevermore. In Jesus' name we pray. Amen.
Amen. Amen. Wow. Okay, go ahead, Rose.
Yeah, I just wanted to give a vote of thanks to Eva and the whole group who organized this for us. We really appreciate. And we look forward to having another session, hopefully with a bigger team. Thank you so much for your time, for your resources, and for the patience. Thank you so much.
You're welcome, Rose. And I thought Lydia also said she had a problem sending the question. Dr. Frost, do you mind if she asks a question, or I can send on the email?
She can ask the question.
Lady, are you there?
So we can't hear. This is
Can hear.
We still can't hear her.
Let me see whether I can call her.
Yeah, call her so that she can talk on the phone.
while she's here.
Yeah, what's the question? Yeah, say the question like everyone can hear.
You have to put the speaker on.
Can you hear me now?
Yes, we can hear you.
Oh, yeah. Dr. Frost, first I want to say thank you so much. The meeting was powerful, very helpful. You have been impacted us, and may the Lord God bless you mightily for helping to understand our bodies and even steps to take out of there, the way you have ministered unto us. Thank you so much, even with Sister Eva. My question was about the vitamin D that you finished with. A friend of mine, not long ago, like 2 months, they went for a conference, and this conference, there was a topic for the vitamin D, and they say a research has come and it's not that helpful. I don't know what would you say about that? I'm not against how you encourage us about it, but I don't know whether the information is out there or what, but a very source, I got this information for a very good resource, one of the doctors that went for that conference. Thank you.
What can you tell me again what they said about the vitamin D? I couldn't hear that part.
What did they say about vitamin D?
Like the way we normally take it, that it's not that helpful, whether you take it or not. I think that's the latest research. I was shocked because it was me, I do take it.
Yes. So yeah, I haven't heard that just yet. There are a lot of times where we, I don't know if you remember vitamin E. That used to be the one where they say, take a lot of vitamin E, and now you don't hear about it much. And so right now we do say to take vitamin D. And so I have not heard a lot about it's not being beneficial, but it's not uncommon in the medical world for things to change. So we will be listening out for this to see if something has changed with that. But for right now, I would still encourage it. But thank you for giving us the heads up just in case, because things do change sometimes.
Thank you. And thank you for that powerful prayer. I don't know how many of you have been to a doctor that prayed for you. So for me, I haven't. So that is so awesome. That's why I encourage you to move here.
Oh, thank you.
So thank you. Yes. Nothing else out there?
Hello, Sister Eve. Can I ask a small question?
Sure.
Yes. I was wondering, during menopause, can you experience dry eyes?
You know, I think just as we age in general, we get dry eyes because even now, and I'm not in menopause, experience dry eyes. And sometimes I think it can run in families because I noticed my grandmother has dry eyes. So I use eye drops when I can remember to help with that. And even I've noticed I've had trouble now wearing contacts. I wear them sometimes, but I get a lot of dry eye symptoms. Now, I did learn from a patient who had another condition that was affecting her eyes that she said gluten can be inflammatory for the eyes for some people, especially if you have a sensitivity to gluten, which is in the wheat. And so oddly enough, I noticed when I was over in Uganda and eating all that fresh food, because you know the food overseas is different than our food here, and probably less gluten and everything, I didn't have as much problems with my eyes. So some of it could be dietary, but also some of it is just age related. We make less of the lubrication, just like in other parts of our bodies, we may not have as much lubrication. We can see the same changes with our eyes. So you may need some eye drops, and you can look for dietary changes too that may help. And make sure you drink lots of water. We have to stay hydrated.
Can I also comment something about the dry eyes, please?
Yeah, please.
Yeah, I would like to add that if the person who asked the question, if you are experiencing even a dry mouth, you are also experiencing dryness in the other areas we already talked about. Like the doctor said, lupus could be one condition, but there's another condition called Sjogren's. So if you've been experiencing the symptoms for a long time, then you might need to see a specialist to make sure that that's not the condition that is going on, lupus or Sjogren's syndrome.
Yeah, there are autoimmune conditions that can affect your ability to secrete those, with the dryness and dry skin and tight skin. And there's a lot of things that can go together with those autoimmune conditions. So you're absolutely correct, Rose.
All right, are we done? I have put out there, if you have any further questions, to please email info@Grace Resource Ministries, and I can forward to Dr. Frost. Because it's, I think we have to, unless there's a woman-related question, I think I want to end this meeting for the doctor. She gave us 2.5 hours. All right. So again, thank you so much. We already prayed, and thank you, ladies, for coming. Again, if you have any questions, further questions, or if you think of something else that we did not address, please feel free to email info@graceresourceministries.org, and I will forward those questions to her. Again, Dr. Frost, we cannot thank you enough. Thank you for your time. Thank you. Thank you. We appreciate you, and may God bless you so much. Increase you and add to you a good measure, pressed down, shaken together, adding and overflowing. Oh. Thank you so much, and thank you to your when I say appreciate your husband for giving you. He's a priest of the home, so if he had said no to this, we would have been in trouble. So we want to also thank him for allowing your time together to come to talk to us as women. Thank you, and we welcome you. I'm sure we would really appreciate you another time. I know with your busy schedule is hard, but we'd love to have you again. Thank you so much.
Yeah.
And I'll end the meeting.